Okay, good afternoon, good evening, everybody. I'm very delighted today to be with you. Thank you, Dr. Isa, Dr. Yaqub, Dr. Tariq, and all the members of the Oman Nephrology and Transplantation Society for inviting me to participate with this talk. Today, our talk will be about a very common problem in our patients, which is a chronic kidney disease, mineral and bone disorders, current perspectives. This is a very common problem. Every day we are dealing with such patients. Today, the outline of my talk will be about the pathophysiology of chronic kidney disease, mineral and bone disorders. Also, I will highlight some new players in the pathogenesis, because understanding the pathogenesis of such a problem is very important for treatment. We'll talk some points about the pathology, the clinical assessment, the workup, the management, and review of some guidelines, mainly KDIGO guidelines. So I will start first with the basics. Many years ago, the National Kidney Foundation attributed the chronic kidney disease, mineral and bone disorders due to decrease of vitamin D secretion from the diseased kidney. At the same time, phosphate retention from a diseased kidney. All of these will lead to hyperparathyroidism, causing bone disease, fractures, bone pains, marrow fibrosis, and erythropoietin resistance. At the same time, the hyperparathyroidism will also lead to some systemic toxicity, mainly cardiovascular disease, hypertension, inflammation, and calcification. However, I believe this is an old-fashioned pathology for the bone disease in the chronic kidney disease. After the discovering of the new players, the first of them was discovered many years ago, also is the fibroblast growth factor 23, which is in fact is the main pathology in our topic. The fibroblast growth factor 23 is secreted, is a hormone secreted by osteocytes and osteoblasts. And in fact, it acts on its main target, which is the kidney and parathyroid gland. The FGF23 have many actions. The most of them is that inhibits 1-alpha hydroxylase in the kidney, reducing vitamin D. It reduces PTH, and it reduces or inhibits the sodium phosphate receptor in the kidney, leading to phosphaturia. In patients with chronic kidney disease, they have high level of fibroblast growth factor and have low level of its co-receptor, which is alpha-Klotho. Alpha-Klotho is a co-receptor for fibroblast growth factor, and this is markedly decreased in chronic kidney disease. This is a simplified diagram of the Klotho, which is a gene that was discovered maybe 25 years ago. It is an anti-aging gene. Animals with loss of Klotho gene developed premature aging. This co-receptor is very important for the action of fibroblast growth factor. It consists of mainly the extracellular domain, consists of two molecules, Klotho 1 and 2, and it can be cleaved by an enzyme called secretase. In our blood, we have the cleaved Klotho and the secreted Klotho. This Klotho is sensitized in the renal tubules. That's why in patients having chronic kidney disease have a low level of Klotho. And this, in fact, is the main problem in our patients, the Klotho FGF23 axis. We have three types of interplay between Klotho and FGF23. The membrane Klotho, which is a co-receptor for FGF23. Therefore, FGF23 cannot work except in the presence of an intact Klotho. There is a soluble Klotho, which is also binding FGF23 and prevents the deleterious effects of FGF23. And unfortunately, there is an independent FGF23 working without Klotho, and this is the pathologic form of FGF23. For patients with CKD have low Klotho messenger RNA in the kidney. The serum and the urinary Klotho can be a surrogate marker for renal Klotho. And in fact, Klotho level starts to decline very early in CKD, starting stage 2 CKD, even before the start of FGF23 rising or PTH rising or phosphate rising. The first thing to occur is a decrease of Klotho level. And in fact, animal experiments showing low level of Klotho had vascular calcification, cardiac fibrosis, and cardiomyopathy. This diagram shows the different molecules changing in chronic kidney disease. And as you see, the Klotho level starts to decrease very early in CKD compared to other players here. You see now Klotho starts to decrease early in CKD, even in CKD1. FGF23 starts to rise at CKD3, and finally PTH and phosphate are late increasing in starting from CKD3 or even CKD4. The FGF23 is causing many morbidities and mortalities in CKD because FGF23 is not working in chronic kidney disease patients due to deficiency of Klotho. Unfortunately, the Klotho negative FGF23 will induce pro-hypertrophic signaling pathway, causing left ventricular hypertrophy and later on also vascular calcification. This interesting study done two years ago showed that FGF23 will act directly on the cardiac myocyte and will activate the calcineurin pathway, the NFAT, the nuclear factor activator of transcription, causing pro-hypertrophic effects on the cardiac muscle. This means that FGF23 will cause cardiac hypertrophy and heart failure and ischemic heart disease. And as you see, this journal is for pediatrics. So this pathology occurring in adults and also in children. So now we are targeting cardiovascular disease. We are not just talking about bones and calcium and phosphate as before. We are mainly targeting the cardiovascular disease related to these disorders. And as you see here, the morbidity and the mortality in CKD due to FGF23 is due to left ventricle hypertrophy, myocardial infarction, strokes, endothelial dysfunction, and finally vascular calcification, which in fact very difficult to treat. This interesting study showed that it was done in Japan in the DOPS study, showing decrease of the level of FGF23 as far as the patient dialyzed. So they followed up the patient 3 years. In the first year, the adjusted hazard ratio is decreasing year after year, 1.1, then 1.15, and then 1. And they conclude that long-term dialysis patients may be less susceptible to the detrimental effects of FGF23 or correlated biological process. That's to say, the deleterious effect of FGF23 is decreasing as far as dialysis is continued appropriately. Also, there are two new players which may present a hope in the future because they discovered a pathway important for the skeletal development and maintenance of bone, which is called WNT beta-catenin pathways. Now we are having two new players in the bone disease in CKD, which is the DKK1, which is the DKOP-related protein 1, and the sclerostin. And these are in fact increased in CKD, and they are contributing to vascular calcification and adynamic bone disease and CKD MBD in general. And interesting enough that there are now animal studies about sclerostin antibodies, and they discovered that it increased the bone volume and increased the mineralization, and maybe sclerostin antibody will be a hope for future management of adynamic bone disease. Now, a few words about the pathology of CKD MBD. The most famous is the osteodystrophy, where the cancellous bone will be increased with loss of the cortical bone and deposition of immature collagen. And a patient may have loss or gain in the bone volume, but the bone is very weak because it is mainly cancellous bone. One of the commonest forms is the high turnover renal osteodystrophy and osteosis fibrosa. Bone resorption rates can lead to osteopenia and then progress to osteoporosis. And that's why osteoporosis in CKD patients is not the classic osteoporosis we are seeing in the general population. It is in fact a sequelae of renal osteodystrophy. This is a common form we are seeing in advanced cases with renal osteodystrophy, the brown tumors, the loss of cortical bone and increasing cancellous bone. Here's the low bone density, and this is very famous of the high turnover bone disease. Another form, which is the adynamic bone disease, which in fact more complicated because it is due to low PTH signaling, and it's characterized by low bone turnover. And in summary, it is a resistance to the action of PTH or parathyroid hormone. This may be attributed to two main problems. The disease-related problems, malnutrition, diabetes, CKD, may increase oxidative stress, hyperphosphatemia, calcitriol deficiency and magnesium deficiency. All of these will lead to reduced PTH signaling. And also, it's sometimes our fault due to calcium overload from overdosing of oral calcium for treatment of hyperphosphatemia, parathyroidectomy, overdose of vitamin D agonists, and some calcium mimetics. This will lead to low turnover, and patients having low turnover, in fact, they have no specific treatment for this disorder, and also they may develop vascular calcification. This is a biopsy of the normal bone having abundant osteoblasts, and this is the adynamic bone having almost no osteoblasts. And this is a tetracycline labeled scan showing the deposition of the cortical bone in the normal bone, and here deficient cortical bone deposition in the adynamic bone disease. To summarize, all the players in the various CKD stages, we are having uremic toxins that are increasing, FGF23 that's increasing, the WNT inhibitors, which are the new ones, the parathyroid hormone, which will rise almost at CKD 3 or 4, and finally the phosphate, which will rise stage 4. And we have reduction in the level of Klotho, which starts very early in CKD, and low level of vitamin D. And also I would like to note that even low bone turnover disease starts earlier than high turnover disease, maybe at stage 2 compared to high bone turnover disease. Finally, another main problem in the CKD MBD, which is the hyperparathyroidism. And now, in fact, hyperparathyroidism is very difficult to treat because the medical treatment is somewhat challenging, and also surgical treatment is not satisfactory in many patients. The causes of hyperparathyroidism, which in fact secondary hyperparathyroidism in CKD, is mainly due to Klotho deficiency. Because normally the FGF23 is depressing the level of PTH. But due to the deficiency of Klotho, this FGF23 is not working. Also, the phosphate retention causing high PTH, hypocalcemia, and low level of vitamin D, which is a calcitriol, due to loss of functioning nephrons, increased also FGF23 level and deficiency of vitamin D binding protein. But in fact, the main cause of hyperparathyroidism is the Klotho deficiency and the lack of the suppressive effect of FGF23 level. Therefore, there are many options for treatment of secondary hyperparathyroidism. I'll talk about this later in the clinical part, targeting FGF23 or vitamin D or calcium sensing receptor, which is also a very important and interesting target for treatment of secondary hyperparathyroidism and control of phosphate level. The secondary hyperparathyroidism pathologically starts with the diffuse enlargement of the parathyroid gland, followed by the nodular form, and maybe in late stages there is a single nodule. So it may be multinodular, it may be a single nodule, or even maybe diffuse. Finally, the final part of our problem is the vascular calcification, and it can be present at different layers of the arterial wall, intima, media, or both of them. The patient may develop plaque rupture or acute vessel occlusion due to intimal calcification. The patient may also develop arterial stiffness due to medial calcification, and some patients may develop calcification on top of atherosclerotic arterial disease. That is that figure showing intimal calcification. In these patients, they develop vessel stenosis, hypertension, atherosclerosis, and occlusive arterial disease. Other patients may develop medial calcifications, that means calcification of the media. They might have vessel wall stiffness, high blood pressure, high pulse pressure, left ventricle hypertrophy, and peripheral arterial disease. And also, this is a challenging problem because until now, there is no satisfactory treatment for the vascular calcification problem. There are some agonists and inhibitors of the vascular calcification because, as you see here, the increased level of phosphate and calcium will change the contractile vascular smooth muscle cell in the vascular smooth muscle wall by active deposition of phosphate, leads finally with a complex procedure into osteochondrogenic cells. So the contractile vascular smooth muscle cell will change finally to osteochondrogenic cells. So the vascular smooth muscle cells will behave like bones. There are some agonists, such as bone sialoprotein and alkaline phosphatase, and some inhibitors such as matrix GLA protein and osteoprotein and FIT1A, which is commonly reduced in CKD. Fit-1A reduction may enhance vascular calcification. So now we are having many challenges, as I have discussed in the previous slides. Now we are moving to the second part of my talk, which is the clinical approach. How to deal with such patients after understanding all these complex pathogenesis. The first of all, we should assess the patient clinically, laboratory workup, imaging, including X-ray and assessment of vascular calcification. Some patients may need bone biopsy. We'll talk shortly about some important medications and modification of our dialysis prescription. The most important clinical aspects we are respecting in such patients is the increased cardiovascular mortality, hypertension and ischemic events, musculoskeletal symptoms, including bone pains and fractures, pruritus, which is due to PTH and phosphate, and finally the calciphylaxis, which is a calcemic uremic arteriolopathy, CUA, which means cutaneous arterial calcification and subsequent tissue ischemia and infarction. And in fact, the patient, when he reaches this stage, the mortality rate will be very high and the treatment will be so challenging due to the associated cardiovascular risk. According to KDIGO, we are starting measuring calcium, phosphorus, PTH, and alkaline phosphatase starting from stage CKD 3A, and in children, they suggest such monitoring in CKD stage 2. So there is no benefit of checking these in CKD 1 or 2. KDIGO have also listed a nice algorithm for checking these calcium, phosphate, and PTH alkaline phosphatase. For example, in stage 3, it's checked every 6 to 12 months. In stage 4, every 3 to 6 months. And now we are starting to check PTH in stage 4 every 6 to 12 months. In stage 5, including dialysis patients, they recommend to check calcium and phosphate every 1 to 3 months, and for PTH every 3 to 6 months. In patients CKD 4 and 5, including dialysis patients also, we are starting to check the alkaline phosphatase, which in fact is gaining more interesting attention these days, because it is the bone-specific alkaline phosphatase may actually reflect the high turnover bone disease. At least it should be checked every 12 months and more frequently in patients with hyperparathyroidism. Also, according to KDIGO, in patients with stage 3 to stage 5D, they suggested that measurement of 25-hydroxy vitamin D to be measured, but the recommendation is weak, recommendation 2C. And also they suggested that vitamin D deficiency and insufficiency be corrected as recommended for the general population. However, the challenging part of giving vitamin D to CKD patients may pose them to hypercalcemia and hyperphosphatemia. And the most important, in fact, in my opinion, in this recommendation is that the decision should be based on trends rather than one single laboratory value. We are not measuring calcium or phosphate once or PTH once. The most important is the trend. Is it a rising trend or is it a decreasing trend? As shown here, the recommended targets by various guidelines are a range, a normal range. Here in KDIGO 2009, the recommendation of corrected calcium level is to keep the calcium level within normal range. The same stands for phosphorus. And the PTH 2 to 9 times the normal value, because there is PTH resistance in CKD patients. However, on the updated guidelines in 2017, KDIGO have modified the recommendation to reduce calcium to be near the normal range, and also the phosphate to be near the normal range. And also they stated that individual values of serum calcium and phosphate to be measured, and the old-fashioned calcium phosphorus product should be abandoned because it doesn't reflect the actual risk. One of the important modifications also is the serial management of phosphate, calcium, and PTH. As I said before, the trend rather than a single measurement. So the trend, is it a rising trend or it is a reducing trend? And their recommendation is to correct the levels of phosphate and calcium toward lowering the phosphate, for example, towards the normal range, and it is not necessarily to be within the normal range. Towards the normal range is satisfactory. And also interesting enough that there is an absence of data that efforts to maintain phosphate in the normal range are of benefit in CKD3 and CKD4 patients. They didn't find a statistically significant benefit of reducing phosphate to normal levels in stage 3 and stage 4 CKD. Regarding calcium, they modified the previous recommendation to keep calcium in the normal range, because in fact, I believe the theory behind this is that the 99% of our calcium are present in the bone and not in the blood. We are checking calcium in the blood. And therefore, in summary, they recommended to keep the calcium towards the normal range, suggesting to avoid hypercalcemia, because hypercalcemia is proven to cause vascular calcification and high cardiovascular risk. And in children, to keep according to the age-appropriate normal range. The second important point is that mild or asymptomatic hypocalcemia is not that important. So the patient, if he has a mildly decreased calcium level, this should not be corrected except if the patient has symptoms of hypocalcemia, arrhythmias, or long QT interval syndrome. Regarding the control of hyperphosphatemia, as we all know, the normal renal excretion of phosphate is about 5,400 milligrams per week. And in hemodialysis patients having 3 sessions, satisfactory sessions per week, only will reduce about half of this amount, which is 2,700 milligrams per week. There is almost zero excretion of phosphate in dialysis patients, and the rest of the phosphate will cause vascular calcification in addition to calcium. The first step is in controlling hyperphosphatemia is diet control, avoiding high phosphate-containing diet. And in fact, a lot of our patients are not compliant in these regards. The second, which is the most important in my opinion, is the phosphate binders, the aluminum-based phosphate binders, the calcium-based phosphate binders, and the non-calcium-based phosphate binders. The aluminum-based phosphate binders are in fact discouraged due to the severe side effects witnessed before due to aluminum, including osteomalacia and encephalopathy. The calcium-based phosphate binders, the calcium acetate and calcium carbonate, they have been very popular. However, the risk of hypercalcemia, PTH suppression, and vascular calcification is there. And the recommended dose not to exceed 1,500 milligrams per day elemental calcium, and it should be taken during meals to reduce the dietary phosphate absorption. The common side effects of calcium, the patient usually report constipation, but we are not concerned about constipation. We are concerned about hypercalcemia and vascular calcification. That's why the Sevelamer, which is an important non-calcium phosphate binder, have a safer cardiovascular profile compared to calcium. And this study, published in the CGS in 2017, compared the mortality between the patients receiving Sevelamer versus calcium-based phosphate binder. And as you see here, there is a 14% lower risk of mortality compared to patients having calcium-based phosphate binder. And the cause is clear, is the reduced incidence of vascular calcification and cardiovascular risk. Sevelamer hydrochloride is a calcium-free resin-based phosphate binders that have been available since 1998. Sevelamer binds to phosphate in the GIT and reduce the absorption of phosphate. The only problem in Sevelamer is that previously it has been Sevelamer hydrochloride, and therefore the level of hydrochloric acid, and the level of the hydrochloric acid was high, that may cause the patient to develop metabolic acidosis. But now it has been replaced by Sevelamer carbonate, which is very popular now in our use, and we are using it here in Oman very popularly. The drawback is the GIT side effects and the high cost, and it may reduce the bioavailability of some fat-soluble lipids. Other phosphate binders, they are in fact less popular, at least here in the Middle East, is the lanthanum carbonate, the sucroferric oxyhydroxide, and others such as magnesium carbonate and ferric citrate. For example, this study compared the lanthanum carbonate versus calcium carbonate regarding vascular calcification and cardiovascular mortality. And at the end, treatment of hyperphosphatemia with lanthanum carbonate did not reduce the composite cardiovascular events in dialysis patients. Not the same situation in Sevelamer. Sevelamer, in fact, reduced cardiovascular mortality compared to calcium carbonate. What about KDIGO recommendation in this regards? As I've said before, they recommended to reduce phosphate levels in patients having progressively elevated serum phosphate and restrict the dose of calcium-based phosphate binder. Now, calcium-based phosphate binders are not popular, and also limiting dietary phosphate intake starting from CKD stage 3 until our dialysis patients. They limit dietary phosphate intake. However, the recommendation for this is weak 2D because sometimes limiting dietary phosphate will be accompanied by limiting dietary protein also. Many of our patients are avoiding to eat meat, for example, and they develop protein energy malnutrition while they are controlling the phosphate level. What about dialysate calcium? We have three popular dialysate calcium concentrations, the 1.25, the 1.5, and the 1.75 millimole per liter. According to my personal opinion, the 1.5 millimole per liter can fit most of our patients. The 1.25, the low calcium dialysate, have less risk of hypercalcemia and calcification, and may be useful in patients having adynamic bone disease. However, the drawbacks are arrhythmias, long QT interval, and hypotension. The high calcium dialysate, which is now less popular, may be useful in hyperparathyroidism, may be useful in hypocalcemic patients, but of course, it poses the patient to hypercalcemia, vascular calcification, and the high cardiovascular risk. This interesting study showed the probability of sudden death in using a very low calcium dialysate in a patient having hypercalcemia. It compared the probability of sudden death regarding the calcium gradient between the patient's calcium and the dialysate calcium. And as you see, as the gradient increases between the patient calcium and the dialysate calcium, the probability of sudden death increase. And that's why KDIGO guideline recommended or suggested using a dialysate calcium between 1.25 calcium less than 1.5, but it is not recommended. And as you see, also the recommendation here is 2C. It is not a strong recommendation to use a dialysate calcium between 1.25 and 1.5, but at least try to avoid the 1.75 as much as you can to reduce the incidence of vascular calcification. Also, one slide about the recommendations of KDIGO regarding vascular calcification. They suggested the use of a lateral abdominal X-ray or lateral abdominal radiograph as a reasonable alternative to the CT-based images. Previously, they were dependent about the CT coronary calcification. Now, the lateral X-ray imaging of the aorta can show vascular calcification, cheaper and simple and available in all centers. And of course, all these patients are considered high cardiovascular risk. Now we come to a question which is usually very weird. Should we screen and treat osteoporosis in dialysis patients or CKD patients? In the previous guidelines, no. There was no recommendation to screen regularly for osteoporosis. It seems that osteoporosis is now gaining more interesting value in CKD patients, and now they changed the recommendation. The testing is bone mineral density is done if the results will impact treatment decisions. So if there is a plan for treatment of osteoporosis, we check DEXA scan. If no plan or the decision will not be changed, there is no use of checking DEXA for our patients. How to treat the patients? The recommendation in simple, this is a strong recommendation, 1A. In CKD stage 1 and 2, we treat osteoporosis according to the guidelines for the general population. For stage 3, we treat as a general population if the PTH is normal, and we use both medication can be given in CKD 3 to CKD 5D, the bisphosphonates such as alendronate, and the denosumab, which is a monoclonal antibody against the rankle. which will reduce the action of osteoblast and reduce bone resorption. Now, denosumab given once every 6 months is in fact gaining more popular use in patients having dialysis, but the risk also of adynamic bone disease is still there. Is there a role for bone biopsy? The same stands as management of osteoporosis. If we know that management will change after we take the bone biopsy. The indications for bone biopsy include unexplained fractures, refractory hypercalcemia, suspicion of osteomalacia, and if there is an atypical response to standard therapies or elevated PTH, or progressive decrease in bone mineral density despite standard therapy. So we are giving denosumab, for example, and there is no response. At this stage, we should proceed to bone biopsy. So the patient is having refractory hypercalcemia or suspicion of osteomalacia. The final part of our talk will be about hyperparathyroidism, which it's a very challenging problem in our patients. The first step is how to assess hyperparathyroidism in CKD patients. We are having 3 assays. The first generation assay, which is the radioimmunoassay, but it's not specific and have some cross-reactivity. The second generation assay, which is the more popular right now, it measures 2 immunodiometric sites, the intact PTH or the full length PTH and the 784 fragment, and the third generation assay, which is measuring divided by the C-terminal PTH, which is the 784, and in fact the ratio more than 1 will predict the high turnover disease. The most commonly measured in our laboratories is the intact PTH or the full length PTH. According to KDIGO, in patients with CKD 3 to 5 not on dialysis, the optimal PTH, in fact, is not known. We cannot tell the patient your optimal PTH is X or Y. The level is not known in CKD 3A to 5. But the only suggestion is to reduce PTH if it is progressively rising or persistently above the normal limit for the assay. And this patient should not receive a direct medication to treat hyperparathyroidism, but the main action will be treat the modifiable risk factors such as hyperphosphatemia, hypocalcemia, and high phosphate intake. And the recommendation is not strong. It is a recommendation by 2C. Also, in other patients with CKD 3 to 5 not on dialysis, is suggested calcitriol and vitamin D analogs not be routinely used. It is reasonable to reserve the use of calcitriol and vitamin D analogs for such patients with severe or progressive hyperparathyroidism. So the routine use of vitamin D in these patients is not recommended. What about the PTH target and the control? According to KDIGO, as I said before, the recommended target is 2 to 9 times the normal limit for assay. And in patients with CKD stage 5 on dialysis requiring PTH lowering therapy, they suggested the use of calcium mimetics, calcitriol, or vitamin D analogs. I will talk a few minutes about each one. The first of them is vitamin D. We have 3 main forms: the calcitriol, which is 125 dihydroxycholecalciferol, the nutritional vitamin D, which is a 25, and the vitamin D analogs, which are now most popular, the alpha calcidol. We are using very frequently